Good evening and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I'll be your host tonight for our program on cancer. We will be glad to take your questions on prevention, diagnosis, and treatment. The success of this program is very dependent on you, the viewer. Please call in your questions and we'll do our best to answer them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Jeff Koopman, a family medicine physician with the Fairview Mesabi Clinic in Hibbing, Dr. Joseph Levine, an oncologist with Essentia Health, and Dr. Paul Sanford, an internal medicine specialist with St. Luke's Internal Medicine Associates. Our medical students answering phones tonight are Laura Hoganson of Grand Rapids, Minnesota, Christy Johnson of Foxborough, Wisconsin, and Paige Nelson of Emmons, Minnesota. And now on to tonight's program on cancer. Maybe we can start out, Dr. Koopman, you practice in Hibbing on the range, and if a patient is diagnosed with cancer there, is that something that they all have to go to Duluth or Mayo or university?
No, absolutely not. We have a large number of outreach physicians that come up. Dr. Levine comes up to the range to help diagnose and treat disease. We have, in Hibbing actually, radiation oncology. We have chemotherapy and resident oncology up there too. So yeah, if you have cancer, you do not have to go down to Mayo, to the University of Minnesota to get your cancer care.
Well, thank you. Well, Dr. Levine, I'm going to ask you maybe a little broader question here. Is there more cancer now than there used to be? Does it just seem like that?
It kind of actually does seem like there's more cancer nowadays than perhaps there used to be. For the most part, with the exception of maybe lymphomas, which have gone up a little bit over the last maybe 20, 30, 40 years, the incidence of most cancers have stayed about the same. Certain cancers have gone up quite a bit. For example, prostate cancer in the last maybe 20 years or so, with the prostate serum antigen as a blood test being sort of a marker, at least in some patients, for prostate cancer, and more screening, more biopsies then tends to increase the incidence. But for the most part, many cancers are really staying fairly flat.
Let me ask you a follow-up question. Are there any that have gone down?
In terms of incidence or cancer mortality?
Incidence.
That's a really good question. I don't think so. I think most. Correct me if I'm wrong.
Either stayed the same or gone
But I think
up.
most of them have stayed the same or gone up slightly because of screening.
Okay.
Hopefully lung cancer in males will start dropping down.
Yeah.
Last it was still going up in women, but I think it almost
Yeah.
leveled off in
Yeah.
males.
Yeah, certainly the mortality from lung cancer has kind of gone down a little bit over the last few years, and the age-related mortality from gastric cancer has gone down over the last 100 years. And I believe that's due to the more advancements in the surgical procedures as opposed to the chemotherapy that we use. But hopefully as we get better at screening and detecting cancers early and at being better at treating them, the age-related mortality will continue to fall for many of these malignancies.
Well, thank you. Well, Dr. Sanford, you must, you see a lot of patients that you counsel, and one of their questions is, well, how do I prevent cancer? Are there some simple ways to do that?
Oh, absolutely. If we can prevent cancer, then Dr. Levine here will be selling Buicks. But no, it's important to, first of all, not smoke. And if it weren't for tobacco, all of us would be doing something else for a living. Alcohol in excess is also a terrible thing. Chewing tobacco, especially in teenagers, horrible head and neck cancers that we see. Sitting out in the sun, getting terrible burns and melanoma skin cancer, that can be preventable. It's healthy lifestyle, trying not to eat just cheeseburgers, trying to eat your fruits and vegetables like Grandma told us to do is really a valuable thing.
Well, thank you. Dr. Koopman, we have a caller from Proctor who wonders that her husband was diagnosed with lung cancer after the doctor examined his fingernails. How did the doctor know to get a chest x-ray?
Well, what happens is that sometimes with certain pulmonary malignancies, you get something called clubbing. And what clubbing is that the end of your fingertips will actually become enlarged from the joint distally. That can be associated with not just lung cancer, but with COPD, which is a chronic lung disease. They really aren't quite sure exactly what the etiology of that is, but I would suspect that was the tip-off when you see that clubbing to do a chest x-ray and then diagnose the cancer.
Yeah, it was a very good pickup by that physician.
Yes, very much so.
Dr. Levine, another caller from Fish Lake, is breast tenderness a symptom of breast cancer?
That's a really good question, and classically I've been told that that's not the case, but it can certainly be, depending on where the tumor is located and whether it's invading through the skin or pressing on a nerve or something like that. So changes to the breast are usually in terms of are usually things that are really good to bring up to your primary care provider, especially if you've been sort of lapse on your mammography screening and this sort of thing. So it's not. So the short answer is it's not common, but at least in my own clinical practice, I've actually seen people who have been diagnosed with breast cancer who have had tenderness as one of their only presenting symptoms.
Okay. And I might add a little bit to that is that sometimes, or actually a lot of times when ladies are going through their cycle, their breasts will normally become tender right before their period. And so what I would worry about is that, if it's 3 to 5 days after their menstrual period and they're still having some breast tenderness, and if there's a mass in there that they may not have noticed before, that get checked out. Because as Dr. Levine said, yes, it can be tender and different from the normal cyclic changes that ladies might have.
We have a caller here, Dr. Sanford, and it was just one note on here, colorectal cancer. I mean, it's a broad topic, but could you mention a little bit about screening for it and what's changed maybe in the last 10 years regarding that?
Yeah, colon cancer is just a terrible thing. And before the advent of flexible colonoscopy, there wasn't always a real easy, simple way to look for it. They used to use a rigid proctoscope and then an air contrast barium enema to look for it. But nowadays, with these magical fiber optic tools, you can see the entire large intestine, and if there are polyps, you can take them out. If you leave an adenomatous polyp in the colon after 7 years, there's a 50-50 chance it turns to cancer. Everybody should start screening at age 50. If there's a family history of colon cancer, start screening 10 years before the age of that person who had it. So if a mother had colon cancer at age 52, everybody start getting your colon screenings at age 42. And with a family history, you should be screened every 5 years. People without a history of polyps or people without a family history, colonoscopy every 10 years.
Thank you. Dr. Coltman, we have a caller from Clover Valley who wants to know what are the symptoms that you might expect with the lymphoma? She had mentioned non-Hodgkin's lymphoma, but any type of lymphoma, say, what do people notice?
Well, sometimes there's really not a lot of symptoms. One of the things that we look for, number one, would be just a feeling of not feeling well. Malaise, we call that. Sometimes with lymphoma, you can get something called night sweats, which means that at night you will be sweating profusely, not just enough where it's warm in the room, but enough where you actually have to change your night clothes and change your sheets. Sometimes you can see bone pain. Sometimes with lymphomas, you can have swollen lymph nodes in different areas of your body that you might notice. So the biggest thing that we see in the office for malignancies is just not feeling well initially.
Thank you very much. Mm-hmm. Dr. Levine, we have a question here about Waldenström maculoglobulinemia. I knew I would goof that up, but it's a mouthful.
Yeah, it certainly is, yeah.
But don't ask me to say it again.
Okay.
But tell us a little bit about that.
So Waldenström's macroglobulinemia is sometimes referred to as a lymphoplasmacytic lymphoma. And it's a disorder of the antibody-producing cells, or a specific type of antibody-producing cell of the immune system. And the antibody-producing cells are plasma cells, and antibodies are these large molecules that are used to take care of bacteria and recognize other parts of the environment that are foreign. And this is basically a disorder where you have uncontrolled growth and replication of a particular type of plasma cells that makes a subtype of antibody called immunoglobulin M. This is a very large molecule, and These cells that are hanging out in the bone marrow, they secrete these very large conglomerates of IgM, and then they get into the blood, and they can cause these very profound changes in the blood viscosity. Frequently, patients won't even know that they feel terrible, other than they might feel a little fatigue or whatever. But if the antibody levels can get very high, then they may have changes in their vision or changes in their thinking or symptoms
plugs up the
related.
blood
Plugs up the
vessels,
vessels,
everything
slows things down. Exactly. Yeah. And we treat this nowadays with several types of chemotherapies, and in some very extreme cases, in patients who are very fit and have very severe disease burden, we may even go to stem cell transplant. But that's usually after several different types of therapies have not shown much benefit in any particular patient.
Thank you. Here's a caller from Duluth, Dr. Sanford. This is a great question, and there's not a lot of easy answers, but is lung cancer caused more by environmental or genetic factors?
Boy, that's a mix. Probably most lung cancer is caused by environmental things, tobacco being the biggest cause.
Sure.
But sometimes family histories of malignancy, sometimes just bad luck, exposure histories, people that used to work with radiation in the military, people that work with various types of dyes and contrasts. It's hard to know. Sometimes people who live a perfect life can still come up with lung cancer.
I'm going to ask my own question now related to that. Anyone can answer. What about radon?
So radon's kind of interesting. Radon as a risk factor has been frequently associated with lung cancer. There's a study done in Europe some years ago where I think the incidence of lung cancer because of radon was really only about 2% of pulmonary malignancy. So yes, there is some risk out there. The reality is that your risk of developing lung cancer from something like radon or not eating enough vegetables pales in comparison to the almost 20 or 30-fold risk that it is of 20 or 30 years of chronic smoking, or, for example, the combination of asbestos exposure plus smoking. There was a Dutch study some years ago that demonstrated that they took a look at patients who, in I think Denmark, it was who had a history of smoking. Their relative risk of lung cancer was something like 10 or 11% above the general population. Those patients who were exposed only to asbestos and not cigarette smoking had a relative risk of about 6-fold over the general population. But the two together had a multiplicative effect of about 60% greater than the general population.
Sure.
So environmental causes are definitely a big part of it. What's interesting about cigarette smoke is it actually is causally related to lung cancer, and that's been proven at the molecular level. There was an article in Science in 1996 demonstrating that there's a particular component of cigarette smoke called benzoapyrene. It's metabolized in the body when you smoke it in and undergoes several rounds of oxidative metabolism, and it mutates DNA at non-random points at a tumor suppressor gene called P53. And the gene product is very important in cell cycle control. It's important in DNA repair. And mutations in P53 are seen in about something around 60% of non-small cell lung cancers and around 90-95% of small cell lung cancers. And there's a great body of evidence that's come out since 1996 to demonstrate this. So of all the environmental factors, smoking is by far the most important, and it's really a scientific checkmate. Recent science has basically proven this. This is totally causal.
Dr. Coltman, here's a question from Proctor. What's the difference between small cell cancer and large cell lung cancer? Small cell and large cell lung cancer.
It's a good question. Those are the two major types of lung cancers that we see. Basically, the difference between small cell and large cell is the actual cell type that when you do a biopsy. They tend to appear in certain parts of the lung. The small cell and large cell cancers also have a different prognosis and a different treatment. So without going into a lot of detail, they're basically two major types of lung cancer diagnosed by biopsy, and the treatments and survival may differ.
Thank you. Dr. Levine, here's one from a caller from Duluth, wants to know, Can a person who's completed treatment for breast cancer donate blood?
I don't know the answer to that, nor do I think I've ever been asked this question.
Yeah.
I don't know
Like
any reason
chemotherapy,
why
or
you
people that
can't.
have had chemotherapy, can they donate blood?
Probably not while they're undergoing therapy, but I suppose it would depend on how far out they are. I don't know the
Sometimes
answer to
the
that.
blood
Yeah.
donation people
Yeah.
have very strict rules that
Yeah.
that are overly strict, maybe than would be warranted, but they want to be
Yeah.
extra careful. So
Yeah.
sometimes it's hard to know.
Yeah, it's an excellent question. It's a great
That
question
is,
for
it's a
your
good
local
question.
Red Cross.
I didn't know
Yeah.
that might- I
I
didn't
don't know
know
the
Yeah,
answer to
that's a
that.
great
Yeah.
question.
Okay, Dr. Sanford, are there any noticeable symptoms for pancreatic cancer? That's a tough one.
That is a very tough one. You know, classically pancreatic cancer presents when somebody says, I don't know why my urine is brown, I don't know why my skin is itchy and yellow, and we find an ampullary tumor. Sometimes people will come in with unexplained weight loss and horrible pain right in the mid-gut, going right through to their back. It's not a nice cancer. And
Most times it's fairly large before it's diagnosed. Is that right?
unfortunately, but even when they're still small with multiple spreading parts into the gland and through the ducts, it's very
hard.
difficult to treat.
It's hard. Dr. Copeman, if you get a bad sunburn in your teens, what's the chance that you'll get cancer later in life?
Actually, there's a pretty good chance of that. Malignant melanoma is associated with bad sunburn, especially in your younger years. What happens is that the sun's rays will damage the cells on the genetic level, and as time goes on, they will mutate and increases your risk immensely of malignant melanoma. I might use this as a plug that sunscreen is very, very important, because now we're seeing an increase in the amount of malignant melanoma that are diagnosed because of things that occurred years and years ago. So, and if you're going to use sunscreen, make sure it's an SPF or sun protection factor of 15 or greater, because they found that those that are less than that don't filter out enough of the rays. So very, very important. As Paul said earlier about prevention, don't bake in the sun. There you have it.
Thank you. Dr. Levine, a caller here wants to know what can be done to stop stiffness in the ankles and calves from chemotherapy. Is there anything can be done?
To stop stiffness in the to answer that would be kind of useful to know what drug we're talking about, and there are certain drugs that we use that can cause aches and pains. So, for example, a drug called paclitaxel, after we give the infusion, will cause some achiness in the joints and the bones, and we frequently will use a steroid called dexamethasone, which is a sort of a very potent prednisone, for a couple of days after we give the infusion, and that sometimes can mitigate these nasty effects. But a lot of that has to do in part with what particular drug we're using. It's hard to sort of answer that question
Sure.
in general terms.
Yeah. Thank you. Dr. Sanford, there's another broad question here. What is acute leukemia as far as the causes and treatment?
Yeah, acute leukemia today for children is not as horrible a picture as it used to be when I was a kid. It used to be that very few children with acute leukemia survived. Today, a child diagnosed with acute lymphocytic or acute myelocytic leukemia, isn't it greater than a 95% probability of long-term survival?
Yeah, certainly for acute lymphocytic leukemias, and even some particular subtypes of childhood leukemias that maybe 10, 15 years ago had really poor prognostic markers, are nowadays with stem cell transplantation and new drugs that are coming out have as good a risk as better prognosis leukemias some years ago. Yeah. Acute lymphocytic leukemia in a child tends to confer a better prognosis than acute myeloid leukemia in an adult. That's usually reversed in the adult. Yeah. In the adult, acute lymphocytic leukemia tends to confer a poorer prognosis.
Any ideas for anyone here about what's the cause of leukemias?
Well, the instructions that your bone marrow has for making the appropriate cells somehow get mixed up. Normally, our bone marrow is a factory that makes the white cells, the red cells, the platelets that we need to function. In leukemia, what happens is that the red cell, or the production of the white cells, is very overstimulated and release immature, non-functional white cells. and they can often destroy the other parts of the bone marrow, so we don't have platelets to help with clotting or red cells to help with delivery of oxygen. It's like a particular cell loses respect for its neighbors and just like a marauding pirate takes over.
Thank you very much. Here's a question, and we have two callers with this question, and I think it's a real question here. And Dr. Koopman or whomever, Cancer Centers of America, I know they do a lot of advertising, as do a lot of healthcare organizations do advertising. Are their results really better than the local doctors, or what's being done differently, say, in these large centers such as that?
I might take that one. What usually happens is that when you have a malignancy that may be unresponsive to the traditional therapies, a lot of times there's experimental therapies that are going on at larger centers. They're in trials. And so in some respects that, there can be a better outcome depending on your response to the traditional therapy. As far as the I don't mean to say run of the mill, but for the common cancers and the common therapies, I don't think there's any difference at all between the care that you would get at a cancer center versus the care that you would get locally.
Thank you. That's a good answer. Dr. Levine, we've just got a few minutes left here, 5 minutes left, I think. Just a few quick questions. Can smoking marijuana lead to the development of lung cancer?
Yeah, there's definitely some risk with that. The risk offhand I can't recall, but again, a lot of this has to do with the fact that you're burning something, and the physical act of burning creates these aromatic hydrocarbons that are then oxidized and metabolized in your body, which then cause mutations in DNA. The risk, my understanding, is not quite as high as regular tobacco smoke, but there's certainly
it's still
some risk
there.
Yeah.
Okay, Dr. Sanford, here's a question just for you.
Oh, good.
So are vitamin D supplements cancer preventative if you live in northern climates?
Probably not cancer preventative. There's some anecdotal evidence that says that it'll help you feel better, and some anecdotal evidence that shows that in populations where they have higher vitamin D intake from their fishy foods, that they have lower rates of MS and Parkinson's disease. But as far as malignancy, I'm not aware of any evidence that vitamin D prevents cancer.
Thank you. Dr. Koopman, here's another good question. Is the radiation a person receives from CT scans or PET scans harmful?
Well, in general, they're not, but it's the amount. For getting an occasional CT scan, occasional x-rays, the amount of radiation that you get there is minimal. Cumulative, though, Dr. Levine might be able to help me out. My understanding is that cumulative with a lot of radiation, that there can be some relationship to malignancy.
Yeah, and that's certainly true. And more important, however, more important on top of that is therapeutic radiation, which can have certainly therapeutic benefits. But in where this is probably best studied is in the field of treatment for Hodgkin lymphoma, where patients who are treated with radiations in Hodgkin's lymphoma over 5, 10, 15, 20 years have a higher incidence of solid tumors of the chest and breast. So radiation is definitely a big contributor.
Thank you. Dr. Sanford, how common are shingles during and after chemotherapy?
Well, probably more common than people think.
How about that? Yeah.
When your immune system is being hobbled by chemotherapy or radiation therapy, the ability of your immune system to fight off the varicella zoster DNA virus is going to be lowered, and so you're at higher risk of getting an episode of shingles.
Thank you. Dr. Koopman, are hemorrhoids considered cancerous? Can they turn into cancer?
In and of themselves, no. Some people, though, may be diagnosed with cancer because of their hemorrhoids, because if they're having rectal bleeding, that might prompt a colonoscopy, which you might be able to find premalignant or malignant lesions. But in and of themselves, no.
Thank you. Dr. Levine, 45-year-old woman, in her teens, she had second and third degree burns, and now she has some brown patches on these areas of burns. Is that something that you would worry about cancer potentially?
Would these be second or third degree sunburns, or would these just be burns?
It says second or third degree burns here, so.
You know, any changes to the skin that have occurred over some period of time are always good to be brought to your physician.
Certainly, certainly. I think one of the last questions, we probably are getting near the end here. We'll get back to pancreatic cancer again. A woman from Hayward calls. Is that a hereditary condition?
Ooh, there are rare multiple endocrine neoplasias, including parathyroid and pancreatic cancer, that I don't believe have a huge genetic load. Probably I'd say no. One thing, when you're talking about cancer, you have to remember that cancer is a word and not a sentence. And a lot of times people will be diagnosed and think, oh, this is the end.
Right.
It doesn't necessarily mean that.
That's true. Thank you. Well, I'd like to thank our panelists tonight, Dr. Jeff Koopman, Dr. Joseph Levine, and Dr. Paul Sanford, and our medical students, Laura Hoganson, Christy Johnson, and Paige Nelson. Please join Dr. Ruth Westra for a program next week on skin problems, when her panelists will be Dr. Susan Ash, Dr. Heather Buchholz, and Dr. John Wood. Thank you for watching, and good night.